Thank you. I'm absolutely thrilled to be here today. I have a question I want to ask everybody. I want you to raise your hand if you're a technology person. Okay. Let's see a lot of hands go. I want to raise your hand. Raise it high if you're a non-technology person. Okay, so it's about 2/3, 1/3. I'm going to speak to both of you. I need to let you know I am not a technology person. I am a community collaborator. I have been building collaborations for 20 years. And 9 years ago, in 2000, I will remember it, January of 2000, I was working with a group of physicians and community collaboration, and they realized at that point that if they were going to transform healthcare in central Indiana, which is where I was from, they had to get the hospitals to start sharing data with each other. And at that moment, they had a vision for healthcare that looked very similar to this. It had to be, we have to bring the data to the point of care. And I realized at that moment when the collective aha occurred with the 50 physicians who were in the room is, this is it. I'm stopping here. I'm not going to do economic development community collaboration or education or human services or industry community collaboration or marketing collaborations. I'm stopping in healthcare because I knew the need was so great. And what's so interesting is 9 years later, 1 week ago, the stimulus bill comes out, which is literally a transformative bill. And if any of you have read this, this is not just a bunch of to-dos. This is a comprehensive list of this is what it takes to transform healthcare. It's really exciting, and what was very exciting was Janet didn't sell herself, but she was very instrumental in bringing those collaborators together for the last 10 years so that when the federal government says we got to have a plan, it was ready-made and it was comprehensive. So you are having the conference at the right place at the right time. I put this in the center because this is the driver over the last 10 years, patient care at the point of care and bringing all the data from all the data sources is the win. And if you don't, and I know that it's very difficult. It's very easy to see when you're sitting at a conference, but when you're negotiating with another party on how much who pays or who's going to provide what scope of task to get something done, it gets harder to see. But in the end, we all know that we're going to be there. It's going to be our daughter or our son or our mother or our sister or our spouse who's going to be there with the doctor, and you want that data. So that is our vision. This is a map of what a health information exchange looks like. Now, in the old days, 2 years ago, this was a simple map. In fact, I didn't even have to draw this map until less than a year ago, because we had to start explaining that it isn't just a hospital connecting to the doctors, connecting to the health plan, connecting to the other providers, because what we now have are lots of network neighborhoods. You know, every hospital has their own HIE strategy, and if they don't have one, they need to have one. The physicians now have their own network neighborhoods. A physician came up to me just 2 days ago. He says, I've got a billing system, 600 physicians on it, and I want to form an HIE and connect to the local HIE in central Indiana. He's turning himself into a network neighborhood, and physician communities everywhere are becoming network neighborhoods. The FQHCs and the public health clinics are forming their own networks. Every state has a Medicaid transformation grant. Many of them do, and they're trying to figure out how to make their data available to the community. Lots of quality initiatives are being organized, and those folks are saying, how can we help the quality initiatives get connected? See what I'm saying? So it's no longer connecting individual entities. It's connecting individual entities and network neighborhoods. That is the task. And that makes it really complex because it isn't just the technology. It is people agreeing to collaborate and share the data. We did a map of the medical referral regions. Jim alluded to this. It's the way to figure out how to get people around the table and to agree to share data is who's sharing data with each other now on a paper-based system or an electronic system, because those are the people that you need to organize around. So we did a map. This came from the Dartmouth Atlas, which is Medicare data, claims data. So there's different ways of calculating it. But you can see where your Harrisburg region is. Hospitals, physician practices, providers, clinics, health plans that serve this region are the ones who need to be at the table with Harrisburg. Now, the state's going to look at it from a different perspective. They're going to look at the whole state and say, here's where the medical referral regions, how do we empower and enable those regions to succeed? And that's a different task, but it's the medical referral region, which is the organizing unit, because that's the people who are willing to sit around the table together. We've done lots and lots of health information exchanges in the last 9 years, and some of the principles have stayed the same, and some things change very, very rapidly. We know that you need many, many stakeholders, because whoever is left out, you're always wanting their money, or you're always wanting their data, or you're always wanting their collaboration. We now know what certain core services are that make these work, and I'm going to tell you a little bit about that in a second. We know that physicians are key. We know there's network neighborhoods that you have to work with. And you know that in the old days, we would try to get everybody on one EMR solution, and we would spend months and years figuring out which EMR would we provide as a community. It isn't going to work that way any longer. There are too many EMRs. We're talking standards. So those old discussions we used to have are off the table. But the big issue that is not off the table is financial sustainability. What we know now is with the stimulus package is we have the catalyst to get off the ground, but in the end that catalyst will disappear, and we have to figure out the sustainability. Now I'm going to suggest to you that one of the most important keys to sustainability is physician adoption, and I want to explain that to you in a minute, because most of you know the other reasons that are barriers to financial sustainability, but people frequently forget the physician community. So I'm going to talk about that 60% physician adoption and financial sustainability. Now, those of you, the 2/3 of you who are in the room, who are the IT folks, are going to cringe at this map, because this is not an IT map. This is sort of a logic map on how you organize people. So I sorted this by those people who are data senders, which are at the top. Those are the people who have the data. Those are your hospitals and your labs and your radiology groups. And I'm talking about the bulk of the data to get the system flowing and the data moving. And then your data receivers who initiate the transactions are your physicians. So if you don't get the data flowing between these two groups of people on a massive scale, you never ever reach critical mass. Well, it's a whole lot easier to get to critical mass with the hospitals, because a hospital joins a health information exchange and you picked up a whole lot of lab data or a whole lot of radiology data. But the data receivers are like herding cats. Most communities, 65% of your physicians are in small practices, and you're not going to have a viable health information exchange without them. So we organize the data receivers into different categories. Over on the left-hand side are those physicians who are still receiving messages from your big data centers by fax or print. That's 80% of your physicians. Can't make an HIE work when 80% of your physicians are paper-based. That third one over there is your practice EMRs. Those are probably your large practices. They're probably your employed physicians. Those are your tech-savvy practices who are saying, by God, we're going to do it. And nationally, that's running about 20, 21, 22%. And they measure improvement by, well, last year it was 20%, this year it's 21, we're doing better. But we know to get to critical mass, the rule of thumb we use is 60%. And the feds are now saying we've got to get to 75%. So many of the communities that have moved and successfully gotten to that 60% level have looked for alternative solutions to EMRs. As we get as many docs as we can on EMRs, and let's give them an electronic inbox. Some communities give it to them for free, some give them to them for a very low cost. And the idea here is that you as a community have to figure out how to get all the physicians on board, not just a few. Now, Jim was telling you a little bit about our Dallas experience. 12,000 physicians in Dallas, and we said to them, oh, by the way, you have to get 60% of those. And we knew the panic would set in. Like, of course, why wouldn't the panic set in if you say 12,000? But it was really amazing. We said, do you want data just flow between the physicians? Do you want all those paper-based physicians to become electronic? Then we got to figure out how to do it. And it was very amazing to listen to them go, okay, we could get 1,000 from this box, and we could get 900 from this box, and we can get another 1,500 from this, and 500. And they were able to add it up. So it can be done, but what it is, it's a paradigm shift. It's thinking about it a different way and not ignoring the physicians because they're too hard to rally, but to say we have to figure it out.